Thank you all for being here. This is NMPCTC's second didactic session of the year. And I want to thank Dr. Burlone for agreeing to be our presenter this February day. Dr. Burlone is working up at Christus St. Vincent in Santa Fe in OBGYN and surgery. And she's going to be sharing with us some original research she's doing or has done regarding addressing and mitigating maternal mortality. So a few things to keep in mind as we go forward. I'll be moderating chat. So if you have questions, please just put them in the chat and we'll try to get those to Dr. Burlone as we go. And we'll have some time at the end for a little bit of discussion and questions as well. And then we will be putting in the chat some sign-up links for next month's at the end, as well as a post-didactic survey. So if you'd please fill those out. And with that, I want to thank you, Dr. Burlone, and I'll hand it over to you.
Well, thanks for having me, guys. I guess by having a small group, it means that each and every one of you has to be an ambassador to talk about what we've talked about today, to spread the word. And I hope that the groups get bigger as this continues to take off. So as mentioned, I am an OBGYN. I wear several different hats. Currently, I actually work half-time as a hospitalist at Presbyterian downtown in Albuquerque. I do have my feet still in Santa Fe as well, hence the Christus connection. So I do some surgeries up there for La Familia Medical Center, where I used to work full-time. And La Familia Medical Center is an FQHC in Santa Fe. And so I still am involved with reviewing charts there and teaching residents through the family medicine program in Santa Fe. So I think it's always helpful to understand a little bit of the background where your speaker is coming from. So I wanted to give that perspective. And then a lot of my work with maternal mortality has actually come from working at a district level in the Western United States for work with ACOG, or the American College of Obstetricians and Gynecologists. So I wanted to choose a topic that was appropriate really for a broad spectrum of primary care providers, hence what we're going to be addressing today. And also because you probably see in the news all kinds of headlines about maternal mortality over the past really 5 to 10 years in particular. And all of that comes from seeing that maternal mortality really is a problem here in the United States. And wanting to kind of understand what is the problem exactly. I wanted to address that today and figure out what all of us can do to take a role in reducing maternal mortality. So I don't have any personal or financial interests to declare, so nothing that I'm saying am I benefiting from in any degree. The objectives of what we want to talk about today are the following. Really, I would like for us to understand a little bit better about where maternal mortality data comes from, how it's collected, and how it's analyzed. I don't expect everyone to be a statistician coming away from this talk, but it's really important, as you know, when you read medical literature, as well as the news in particular these days, with hyperbole on all sides of the political spectrum, what really is happening and how can one really absorb the information in a very objective way and understand where numbers come from. So I want to address the history of how maternal mortality data has been collected and really how it's being analyzed as we go forward here in the United States. I want us all to be familiar with the top causes of maternal mortality in the United States and really in New Mexico in particular. Discuss race, rurality, and other social factors as they relate to maternal deaths, and to really understand as primary care providers how we can prevent maternal mortality. So important to start out is really understanding some definitions as they relate to maternal deaths, maternal mortality. You're going to see all kinds of reported statistics in the literature and in the news. So a pregnancy-associated death is a death occurring during pregnancy or within a year of pregnancy, regardless of the cause. So again, that association means that it's related to the timing of a pregnancy, so during or after a year of a pregnancy event, and that doesn't mean a vaginal birth, it doesn't mean a cesarean, it means a pregnancy event. And that's kind of the universe of all pregnancy deaths that we're going to talk about. So within that, a pregnancy-associated death, there's pregnancy-related death, and there's pregnancy-associated but not related death. And a pregnancy-related death truly is a death occurring within a year after pregnancy or during pregnancy that's from a pregnancy complication, a chain of events that's initiated by pregnancy, or really the aggravation of a condition or physiological issue that are from the effects of pregnancy. And so when we're looking at pregnancy death data, we really need to figure out whether it's associated with the pregnancy or really caused by the pregnancy. But most of the time, we're actually not going to see these raw numbers. We're going to see it reported as a pregnancy-related mortality ratio. So that's the number of pregnancy-related deaths using the definitions that I just went through over 100,000 live births. So that's the definition that we're moving towards here in the United States is the pregnancy-related mortality ratio. And you'll also see that as a PRMR acronym. Historically, though, the pregnancy-related mortality ratio was not reported as such. It was reported as maternal deaths or the maternal mortality ratio. And I say historically, but it's actually still the definition used by the World Health Organization as well as the National Center for Health Statistics. So the maternal mortality ratio is a maternal death, which is actually death of a woman during pregnancy or only within 42 days. So here's that distinction after the termination of pregnancy. Again, regardless of the site of the pregnancy, could be an ectopic or the duration, could be a miscarriage or an abortion. And again, does not necessarily include the accidental causes. So this is a death that's determined to be from a pregnancy, but the shorter time frame. And then putting it into a ratio of over 100,000 live births turns it into that maternal mortality ratio. And that's often what you're going to see reported as maternal mortality in the news and in the medical literature. Preventability is pretty self-explanatory as a definition, a death that can be prevented by having interventions to prevent it from happening. So this is kind of a complicated looking graph, but it's actually quite simple. So on the x-axis, above the x-axis is looking at the annualized rate of change in maternal mortality between the years of 2003 and 2013. So if you're in the positives, so above the x-axis, you're not doing well. You're increasing your rate of maternal mortality over time in that time frame. The y-axis, if you're on the right-hand side of that, you're in the positives, not so good again, because you're having an increased rate in maternal mortality over the time frame of 1990 to 2003. So those who are in the upper right corner of this graph are those who have an increased accelerated risk in the earlier time frame of history of the 1990 to 2003, as well as the more recent 2003 to 2013. And just to finish that thought, those four countries that are in that quadrant on this slide are Belize, Afghanistan, the United States, South Sudan, and Guinea-Bissau. So again, not good to be in that upper quadrant and really representing where the United States stands in the world as having an accelerated rate of change over time. So again, we can see here also the United States lags behind other rich nations in maternal mortality. So we're at the top here and really on a exaggerated slope of where we are doing compared to other countries that we should be more in par with. So over time, if we look at the slope of change for the rate of maternal mortality or maternal deaths really over 100,000 live births, we can see the slope is increasing over time as well. But all of this to be taken with a little bit of a grain of salt because of how we've changed our data collection over the past couple of years. So this has data that's a little bit more recent, and I'll explain later when I discuss maternal mortality review committees why we can't have the most up-to-date reporting as of the last year or even within the last 3 or 4 years. But again, all of these slides indicating that over time, the United States is not making improvements at baseline and at worst is actually getting worse over time. So these are the different collection tools that we've used in the United States to collect maternal mortality data over time. So it began with the CDC pairing with the National Center for Health Statistics, using truly death certificates as the way to document maternal deaths. And a maternal death was defined, again, as during pregnancy or up to 42 days after a pregnancy ends. And the way that these deaths were classified were also using ICD-10 codes. So maternal death, we already reviewed that definition. That was really the measure that was used to over 100,000 live births to report this data. But as you can imagine, using ICD-10 codes and death certificates alone was not giving robust reasoning for why women are dying and really giving us any tools to say, hey, how can we make an intervention? And apart from that, death certificates actually didn't even have a checkbox for pregnancy until starting as early as 2003. And even states since then have approached the death certificate checkbox for pregnancy in a staggered fashion. So 2003 was kind of the first time we really started having a box for pregnancy on a death certificate. And even starting then, it wasn't all the states at once that started using the standard death certificate with the pregnancy box. So again, we can imagine wrought with data errors in this way of collecting data in our old way of looking at maternal mortality statistics. So then the CDC developed this pregnancy mortality surveillance system that linked death certificates to fetal death certificates as well as birth certificates. It expanded that time frame to including 365 days after the pregnancy event, and included a little bit more review by medical epidemiologists, and helped us define really, is it pregnancy associated or just pregnancy related, or pregnancy related or just pregnancy associated. And so that gave us a little bit more robust data. But again, we were finding we're not getting all the information that we need of really what is the chain of events? What can we do to prevent maternal deaths? And that is really where we found that maternal mortality review committees are key in figuring out the chain of events that has led to a maternal death. So we still use that same definition of the pregnancy associated or pregnancy related deaths. Again, that 365 days after the end of the pregnancy, but now really that committee can look at medical records, autopsy reports, informant interviews, social service records, and really puts it all together in a much standardized, more standardized fashion and more thorough evaluation. So we know that over time, maternal mortality review committees have taken a process to develop. So reviewing maternal deaths on a committee level usually is at the state level. So there are some large municipalities that have their own maternal mortality review committees. But for the most part, it's states that are putting together these committees that have different diverse members on their committees to be able to help contribute to the review of maternal deaths. So again, we can verify the accuracy of reported information much more by going through more than just death certificates and birth certificates and fetal death certificates. We're able to get medical records and really go through some of the investigative reports as well. So with that information, we're able to characterize the maternal death a little bit better. Was it pregnancy related? Was it pregnancy associated? What truly was the cause of death? Was the death preventable? And what were the critical contributing factors? And that's what really allows us to have opportunities for prevention. So what are the recommendations and actions that we can do as a result of these factors? And what is the anticipated impact from making these changes that we're discovering? So these maps, I think, are pretty revealing of how far the United States has come in the past decade, really, of implementing maternal mortality review committees. So 2012 is the upper map here, and that shows all the darker states are the ones that had maternal mortality review committees back in 2012. In 2017, we can see that jumped up to a number of 28 reviews, and that included some, again, municipalities, New York City, Philadelphia, and Washington, D.C. And then fortunately now, as of the fall of 2021, this is what the United States map looks like. So all of the dark states have a current, all of the shades of blue, I should say, have maternal mortality review committees now. And really, there's only a handful of states, North Dakota, Maine, and Vermont, that are planning a review but did not have one as of this past fall. And again, putting in a maternal mortality review committee requires legislation. It requires funding from the states. It requires an epidemiologist. It requires the health department being on board and having the infrastructure. And then that next step is actually coordinating with the CDC to report the data in a standardized fashion, which I will allude to a little bit later in the presentation. So that helps us move on to, again, now, what are we finding with all of this data? So now we know, okay, we were erroneous kind of in how we were collecting maternal mortality review data before. Now we're making strides and we're really almost up to snuff as a nation on how we're actually looking at this information. What is it showing us? And so, again, the more recent data that we're seeing is more committee-based findings. The older data that I'm going to be discussing is more from the older systems of how we collected it. But we can actually see that even in the most recent years, our primary causes of death to women have not changed significantly over time. So cardiovascular conditions are really the leading cause of death in the United States. So that includes coronary artery disease. It includes valvular heart disease, either acquired or congenital. It includes Marfan syndrome, pulmonary hypertension, vascular aneurysm. So all of that is in that category of cardiovascular conditions. That is not specifically cardiomyopathy. You'll see that as its own bar here on the chart. It's not infection or sepsis, which is really the second cause of death of women in our most recent kind of conglomerate group of data categorization. Hemorrhage being up there as well. Thrombotic pulmonary embolism, cerebrovascular accidents. These are all separate but individual bars here on the graph that you can see are declining in numbers in terms of their incidence as reasons to explain maternal deaths. But you'll see at the end of this graph here on the right is the other category of 12.5%. So that's almost, that's third place for leading causes of maternal death. And really what is in that category is variable because it's categorized as others. But what we're finding, and I'll talk about this in a little bit as well, is a lot of that is related to substance use disorder and mental health disease. So this is, again, looking a little bit older data. I just wanted to bring this slide up for comparison purposes of showing not much change in our leading causes of death, and really that other category comprising number 2 or number 3 place as we're looking at things over time. When we look at by individual complication, what has happened in these timeframes going back to 1987, we see that we've made improvements in hemorrhage. We've made improvements in hypertensive disorder pregnancy, in infection, in thrombotic pulmonary embolism, in AFEs or amniotic fluid embolisms, and anesthesia complications. But where have we done worse? We're getting worse at having a bulk of our deaths come from cardiovascular conditions, cardiomyopathy, cerebrovascular accidents, which we can all relate to the obesity epidemic, but not necessarily directly related. And then again, this other condition, what is this other condition comprised of? So unfortunately, we're also seeing significant disparities, not only amongst conditions over time, amongst different races and ethnicities. So if we look at the pregnancy-related mortality ratio amongst these different categories here, non-Hispanic Black, 41.7 over 100,000, non-Hispanic American Indian or Alaskan Native, 28.3, go down significantly then to non-Hispanic Asian or Pacific Islanders, then comes in non-Hispanic White and Hispanic and Latino. So we can see a great disparity of the breakdown of who is actually dying amongst these different racial and ethnic categories. And we can also see that amongst the different racial and ethnic categories, there are different primary causes of death. As you recall, if we look at all women together, cardiovascular disease was our leading cause of death. But when we look at specifically American Indian and Alaskan Natives, it's hemorrhage. When we look at Asian and Pacific Islander category, also hemorrhage. But amongst Hispanic or Latinos, it's actually infection. So advanced maternal age is also something that for any of you who do prenatal care or who are working on labor and delivery units, you'll have seen that over time we've really changed our treatment of advanced maternal age women in terms of screening during pregnancy and in terms of delivery timing. And a lot of that comes from the data that we've been collecting over recent years of how exacerbated not only are pregnancy complications with advanced maternal age, but even more so the disparities amongst different racial and ethnic groups amongst the category of advanced maternal age. And so this chart here shows you that compared to white women, Black women who are in the advanced maternal age category are over 4 times more likely to die. And American Indian and Alaskan Natives are more than 5 times likely to die. So again, advanced maternal age exacerbates the disparities amongst these groups even more. And we would think that maybe we could find some equalizer of these disparities when we look at factors such as educational level, but not so much. So we can see here in the category of some college education, we have Black women dying at a 3.5 times as high rate and American Indian and Alaskan Natives at 2.7 times the rate. So again, we're not seeing that educational levels are really equalizing and reducing the disparity that we would otherwise perhaps suspect might be affecting things. So is it rurality? Is it because of the geographic location of these women? Is that explaining some of the disparity? Well, maybe or maybe not. 54% of American Indian and Alaskan Natives live in rural and small town areas. So could that be the explanation if we're not finding other reasons to explain this disparity? Well, the CDC has actually tried to look at that. So using the PMSS data, so this is not from the Maternal Mortality Committee review data, they looked at geocoded pregnancy-related deaths between 2011 and 2016, and basically used 5 rural urban categories that are based on the NCHS urban rural categorization or classification scheme of counties. So to say these folks are rural, these folks are not, and where are deaths occurring in terms of rurality related to that data. And what we found is that rurality does disproportionately affect the American Indian and Alaskan Native group because of the significant amount of women who are in this rural category. So if you look at the slide here, the dark blue on the left is large metro areas. The lighter blue on the right is what's called non-core or micropolitan areas, and that's our rural category. And we can see really, again, that the majority of American Indian and Alaskan Natives are in the rural living category. And so is that accounting for the disparity that we're seeing in a lot more American Indian and Alaskan Natives having a higher rate of death? On the other hand, does it explain the Black versus white issue? Because we have more Black folks in the large metro or medium metro areas. So really we had to look at, let's look exactly at the categories of where these folks live, not looking at the race or ethnic categorization. And we can see that just looking at non-core and micropolitan areas, that we have a higher rate of maternal mortality in those geocoded regions. Basically explaining, yes, rurality is a factor, a risk factor for increasing your risk of maternal death. And unfortunately, those disparities do persist when we break it down by race and ethnicity. So Black persons had a pregnancy-related mortality ratio 3 to 4 times higher than white persons, and that was across every urban and rural category. And when we looked at Alaskan Natives and American Indians, they had a 2 to 3 times higher risk of death, but specifically in small metro, micropolitan, and non-core counties. So the advanced maternal age, even more exacerbated amongst the rural versus urban categorization. And so we see that in particular, 40 to 44-year-olds in a rural area are much, much, much higher at risk for maternal death than that same age category in large metro areas. And even when we back that age categorization to 35 to 39-year-olds, again, the more rural areas have a disparate amount of maternal deaths compared to a larger city area. So that's, potentially, again, some of the explanation for why we are seeing these disparities in our particular areas in the Mountain West. And I'm going to get to that in a minute as well. But I also wanted to mention, again, readdress that other category and what we're finding with some of our committee data. So most of the data that I've presented so far as a conglomerate source of data has been from that PMSS data system that was not committee based. So this emblem on this slide, the MMRIA, stands for the Maternal Mortality Review Information App. So the CDC, as it has been helping all of these states over the past couple of years develop their maternal mortality review committees, has developed a database to input the findings of the committees into a centralized location in a centralized and standardized way so that we can compare apples to apples and not apples to oranges. So this data is coming from 6 particular states that have had a maternal mortality review committee in existence, who have had years now to be able to catch up on data and do previous year's reviews, who have implemented the MMRIA system within their state, and who have a data sharing agreement with the CDC. Again, I mentioned maternal mortality review committees are complex. All of those steps need to be in place to actually look at the data, which is just crazy. So we do have 6 states who are on board with this for several years now and able to report about overdose reviews in particular. So RMOR is a CDC program that looked at 104 overdose deaths based on committee findings that included case narratives, contributing factors, and the committee recommendations as a result of these death reviews. And what did we find? Most of you probably won't be surprised at this. For any of you who take care of women in the postpartum period, the overdoses are frequently in the late postpartum period. So in fact, 73% of them. So that is beyond the 42 days immediate postpartum state. And again, beyond the pregnancy state itself, but the bulk again of these overdose deaths are in that late postpartum period. So we know that substance use disorder contributes to 94% of overdose deaths, but we're actually failing on addressing other mental health conditions that are also contributing to these deaths in nearly 3/4 of cases. So 72% 2% of the time, there are other mental health conditions apart from substance use disorder that are contributing factors to these overdose deaths. And furthermore, breaking that down, we're looking at what could have been, what could we have done better. And in about 50% of the time, there were documented missed opportunities for mental health screening. So we're failing in that large category of other, knowing that a lot of these other deaths are related to substance use disorder and mental health conditions, and we are not screening women appropriately. And that is a significant place for where we can be thinking about doing interventions. So it's not all doom and gloom, because there are some success stories for how we've been able to address maternal mortality issues. And specifically, California has been a leader in addressing these issues. A lot of it comes from bundles and packages that are used on the labor and delivery unit, doing drills and having basically protocols in place for addressing some of the issues that we have seen over time decrease. As I mentioned before, we've seen hemorrhage deaths decrease as a category. Even again, as our maternal mortality rises, when we look at hemorrhage specifically, we're doing better at managing hemorrhage as we are with hypertensive disorders. And California has been a leader in creating toolkits that have been used all around the country to be able to address those hospital-specific factors. And they also have a quality care collaborative that is working on other non-hospital issues as well. So we know that interventions can be done when we finally have collected data in a good way, finally have analyzed it and said, this is what the problem is, let's address it, we can be successful. So what can we learn from California? So ACOG District 8, so the American College of Obstetricians and Gynecologists, is broken down into geographic districts. And you can see here on this map, the bulk of the map, and really maybe it's not just not proportionate in the drawing here, greater than 50% of the land mass of the United States is represented in ACOG District 8. And you can see that New Mexico is one of those yellow states that is included. The two western provinces of Canada are also included in ACOG District 8, as is Central America. So what do we all have in common? We're all very rural states. We have lots of mountainous terrain. We have very few, if any, large metropolitan areas or larger metropolitan areas compared to, again, looking at the East Coast or even California, who's a different beast. So ACOG District 8 basically had the idea of saying, well, as we're finally getting these maternal mortality review committees, as we're finally getting data, how are we going to look at it over time when overall, in a very good way, overall the numbers are relatively low in our less populous areas? So when you have hundreds of maternal deaths to review in New York, for example, every year, then you can start looking at trends and start making some analysis based on some robust statistics. But when you have a state that has 5, 8, 20 even deaths per year, it's hard to look at trends over time. So our idea with ACOG was actually to pool data of similar states and similar regions to be able to say, hey, what can we do as a group to be able to look at maternal deaths? And by grouping these similar populations, we can have a larger data set. We can identify solutions to reduce the risk of maternal mortality that apply to multiple states at a time. We're not having to reinvent the wheel every time. We can consolidate resources for implementing change so that we don't all have to, again, be doing the same thing at the same time in multiple different states. And this is a preliminary step to a national database of maternal mortality review data. So ACOG District 8 has been working on this, and I've been the chair of that committee since 2017 to, again, look at data at a regional level. So we have a few states that just within the last year or so have finalized and formalized their legislation to have a committee and have made a maternal mortality review committee. They're just now catching up on data from 2017, 2018 death reviews. So we don't actually have it all in that CDC centralized MARIA is what it's called database yet. But we've had several meetings of all of the healthcare leaders from across ACOG District 8 to discuss what we have been finding preliminarily as states without having official review that we can put data points in. And what those findings are that overdose deaths are at an increasingly rapid rate, accounting for, again, that overall and other category. And we know that across our states, we're all discussing the same problem, that mental health resources are really scarce, and that it's been really hard to find referrals and integrated systems to keep women in the system postpartum for the mental health care that they need. We also are finding that oftentimes the first medical encounter for a healthcare crisis is not in our offices. It's not in our primary care settings, but it's in the urgent care or emergency department. And so that has really helped us learn of who should we be partnering with and who should we be talking to about mitigating and preventing these deaths. We've also seen, and you probably have even seen in your communities, the closure of labor and delivery units and decreasing access to prenatal and postnatal care providers in rural areas. And that in and of itself is a problem, but that's also leading to increased travel to access care. And we actually have had deaths in New Mexico that are a direct result of a car accident from getting to prenatal care. There are women who have died actually transporting themselves to their prenatal care appointments over long distances, again, because it's not in their local communities and quick access. So what does that tell us? All of these problematic findings have led to us proposing some possible solutions for our state and really other rural states within ACOG District 8. And that is to really expand education and entice rural providers to continue prenatal care and postnatal care. So I didn't ask. I know we have just a few folks joining here on the call, but I understand that most of you are family practice based, and having this training of your residents. This is a motivating topic for me to be able to talk to residents about, because this is really what our crux of our findings are. After all the work that we've done to collect data, after all the work that we've done to analyze it, to put it all into place, we're seeing we need more of everyone who's on this call to be doing prenatal care and postnatal care and to be involved with these solutions. So the residency program education with a rural focus is one of our key findings and proposals for what we need to do to make maternal deaths better. And fortunately, I know the Santa Fe, New Mexico Christus program for family medicine has a specific track for OBGYN teaching. I am their OBGYN instructor. I hope that other groups on this call as well are finding ways to make sure prenatal care instruction and didactics are included in the education of residents. And the other thought is, do we need government assistance and education programs or a government assistance program to address the malpractice issue for prenatal providers? What are we doing in terms of incentives of trying to get people on their feet to be able to continue to provide prenatal care? And then furthermore, encourage prenatal care with oversight from a remote reviewer. So, at La Familia Medical Center in Santa Fe, we have very excellent quality care prenatal providers, but we've seen that since the departure of me and other OBGYNs from the center, that we don't have kind of a way of overseeing some of the higher risk pregnancies, apart from maternal fetal medicine consults, which isn't, again, the same as having somebody review and frequently check in with a chart. So at La Familia Medical Center, we've developed a system for me remotely from Ecuador, actually, where I have been for the past 6 years, be able to overview and review high-risk prenatal charts. And we published this as a finding because we're seeing that this is really applicable to any rural area to have an OBGYN or to have somebody with some prenatal and postnatal care expertise oversee the pregnancies until they have to come to the point of delivery, which again, then the delivery place would be triaged. And other possible solutions, again, to address some of the things that we found is to implement some emergency telehealth services to rural emergency departments and urgent care centers. So the PAL system, you probably are all familiar with, really is for kind of critical inpatient consults, but can we have a maternal health line that is really for questions and consults if there isn't this direct oversight of prenatal care like we've established at La Familia? And who can we go to for questions either urgently and from urgent cares and emergency rooms, or even during prenatal care? And can we have an emergency consult service to help with? So the next slide, I just want to kind of address what other small things can we do. So we have the big picture issues that we're addressing from kind of a data analysis perspective, but what do I see as an OBGYN who sees sick patients come in to one of the busiest hospitals in New Mexico? Number one is really contraception to prevent unplanned pregnancies. So we're not going to have maternal mortality problems if we don't have pregnancies. Of course, we're going to have pregnancies. This is part of natural human reproduction. But what about preventing those unplanned pregnancies that are often, again, in populations who are more at risk for having pregnancy complications? So key remembering to discuss contraception at our, well women health visits. If there's anybody who's in pediatrics here, please talk to your patients about contraception, have emergency contraception available. Step one in preventing maternal mortality issues. Step two is just all of us maintaining a broad differential. When somebody comes in with lower extremity swelling, not necessarily jumping to the conclusion that she must have preeclampsia or just normal swelling of pregnancy, but thinking, gosh, cardiomyopathy. I remember seeing that bar graph where it was number 4 in terms of ways that women are dying in New Mexico. Let me remember to keep that on my differential and make sure that I ask questions and or order appropriate tests that would rule out cardiomyopathy versus preeclampsia or normal edema of pregnancy. And then also just remembering normal physiology. There's a lot of times where I get calls from emergency departments that are that use us as a call center at Presbyterian, where they'll discuss a blood pressure that is 140s over 90s, which as you take care of older men and women not in the reproductive years or not related to pregnancy, of course, not a good blood pressure, but not alarm bell that would go off when we know that it's a pregnant or postpartum patient. And the same thing with small things like creatinine. You look over the labs, nothing flagged red. This patient's fine. Her creatinine is 1.0, not normal in pregnancy. Those normal physiology red flags that we don't see outside of pregnancy, we need to remember our specific problems when we see them in pregnancy or the immediate postpartum timeframe. And then also just recalling the expanded timeframe for the post-pregnancy state. So, as we've talked about, historically, we've been looking at 42 days after a pregnancy event ends, and now are expanding that to 365 days afterwards. Well, there's a reason for that. One, pregnancy physiology, the direct physiology and blood volume issues that might change at 42 days and beyond postpartum, but the psychosocial issues do not. And especially as we're thinking about seeing all of the overdose deaths and mental health disorders being an increasing component to our maternal mortality numbers in New Mexico and in our rural states, we know that there are exacerbating factors that are known to cause increased risks of suicidality and even overdose. And that includes childcare. That includes women who are having their children taken away from them from Child Protective Services. So when we know that there is a woman with these factors in her life, again, in that expanded postpartum timeframe, higher on our differential to really be aware of her mental health and whether we're addressing potential problems that are just being pushed under the rug because she doesn't qualify for the Edinburgh postpartum depression scale application anymore. So we really just need to be thinking about all of this as we see patients in the office. And that, again, relates to addressing mental health. So, we're trying to get expanded Medicaid coverage for women beyond those 42 days across the nation. I recently spoke to someone in the Office of Population Management in Washington, D.C., who's saying, hey, I want to know more about maternal mortality. What are we doing? What should I do as the largest insurer in the world? And my response is, make sure that everybody has access to care in that expanded postpartum timeframe and access to mental health services. And then lastly, what I'd like for all of us to consider is becoming involved in the state's maternal mortality review committee. So as I mentioned, we're finding more and more need to diversify not only the healthcare providers who are on our maternal mortality review committees, beyond midwives, beyond OBGYNs, or beyond prenatal providers who are, family practice based, but really looking at people who are doing any type of healthcare of our 50% of our population, aka women, in the community. And really encouraging other community members. We're seeing that having tribal representation on MMRCs, of having lay persons on MMRCs, and then social services as well, is really helping us to get more robust, not only discussions related to how we can prevent deaths in the future, but really what are ways that we can troubleshoot and make programs that are statewide to, again, mitigate deaths. So a lot of you might have heard of the CDC's campaign called Hear Her. And really it's, there's a whole page dedicated to resources that I've copied and pasted onto this slide that is trying to help us be aware. And again, it's not ignoring women when they're complaining about things and saying that's normal. And then, oh crap, I missed something big. It's doing maybe some individual training and implementation of bundles within your hospital system. And it's also becoming aware of ways that you can step up even at a kind of an agency level or a committee level by implementing some of these tactics that we've talked about here today. So I hope that, again, that this has raised some curiosity as to what we all can be doing in terms of improving maternal mortality. I hope that everyone can remember all the things that we talked about on the differential, and then also just have a more critical eye of appreciating the data as it comes forth and being able to participate in discussions in an informed way about really what we can do to mitigate maternal mortality. So thank you, guys. I'd love to have some discussions if folks have questions, and it looks like we had a group that dropped off a little bit ago as well. I don't know. I'd love to know who's on the call here since there's just a few of us.
Hi, so I'm Amanda Provencio. I'm one of the faculty for Memorial Medical, the Family Medicine Resident Training Program. And we do a lot of OB, care.
Great.
And so I think it was really nice to kind of hear the data and kind of realize the other factors that impact morbidity and mortality in this population, and to make sure that we're kind of mitigating in that. So I'm going to look into the HERE campaign more and kind of do those modules myself. So thank you.
Awesome. Yeah.
Suzanne, I'm Dr. Benson, Stephanie Benson. I'm one of the faculty here in Las Cruces as well that does OB. I really appreciate you doing this. I think it's incredibly informative and very helpful. Health policy is kind of my mojo and one of the things that I do on a state and federal level. And I know there's a lot of attention around this on the federal level right now as well. So I really appreciate you taking the time to help educate us and our residents about this really important issue.
Well, great. And I'm seeing there's actually a lot more folks who have joined. As I stopped my screen share, there was a lot more on the list. So if anyone wants to introduce themselves and let me know where you're from. I called out the few people that were on my small little screen of Windows, but a lot of folks here are joining from, I'm sure, a robust group. And I would love to hear questions again, or just hear where you all are coming from.
My name is Davina Norris. I'm here with actually Dr. Pattison. We're both here in Las Cruces with the Family Medicine Residency Program. One recent news that I was thinking about almost throughout this entire presentation is the news about the hospital in Gallup kind of nearing closure. And knowing that, our Native American brothers and sisters have some of the highest rates, and just thinking about the impact that is going to have in that community. But then also thinking I know it's multifactorial as to the causes of why that's going to happen, but how can we also think about perhaps stabilizing budgets for rural areas, rural hospitals, so that we can prevent closures of our rural facilities that are absolutely, critical for certain communities. So just one thought to throw in.
Yeah, no, I heard that news as well. And I think it's such large scale issues that we need to look at, because as we know that Gallup is not the only rural medical center that is closing. What government incentives are there? Are there subsidies to keep some of these more rural places open? Or can we look at models like what Alaska does? And they really have nesting programs. So for women who are in very remote areas, 35, 36 weeks, they come in and stay in facilities in larger metropolitan areas, if we can say that for Alaska, to be closer to a hospital for delivery. And, what kind of resources do we have for that? And are women amenable to that? Can they take breaks from their families? What are the social implications of basically leaving their home for weeks at a time? And it seems to have worked for whatever reason in many communities in Alaska. Could we apply that to here, what we're seeing in New Mexico? I think that's a good question. And again, what is the government doing apart from some of its loan repayment services to recruit providers? But that doesn't address, again, the hospital and the financial aspect of why some of these places are closing. And again, now I think we have the nursing shortage kind of piled on top of all these other problems that we've had, because we're not able to even keep nurses on our labor and delivery units. So I'm not familiar with the particular reason that ultimately Gallup was going to close. And I know that in Las Vegas, New Mexico, they've had openings and closings of their labor and delivery units for similar reasons. And again, and that's, I think, where one of the maternal deaths came from, was someone traveling from Las Vegas to Santa Fe to have her prenatal care. And we're going to see more of that. I mean, that's just an obvious fact.
Just to throw one more thing in there before, and I'll hand it over to someone else. But one thing that New Mexico is working on studying and evaluating is whether or not a global budgeting system for hospitals would be more effective. which might help to stabilize, especially the more rural areas budgets, so that if they see a significant drop in revenue, due to something like COVID, that they would have a dependable revenue stream coming in. So something interesting to keep an eye out for in the future.
Yeah. And I think, one of we always go to, what is the motivating factor for what hospitals do? And unfortunately, that oftentimes has to be economic and has to be bottom line. And we know that unfortunately, labor and delivery units aren't winners for making money for hospitals. So, what can we do to compensate that there isn't this steady revenue and this steady positive income for labor and delivery units when you're not getting necessarily even the prenatal care? So, folks who do prenatal care, they charge one bundle. The folks who do the delivery charge another bundle. So how can we combine? I mean, maybe that's what you were alluding to get this global package of saying you stay open and you get this chunk of change, whether or not you have a high or a low in your delivery numbers, and whether or not you provide the prenatal care, this will keep you open. And I think that we need to look at this at a more federal level. And that's why, ACOG has really been involving some bigger players in these discussions. And I felt like I had a privilege to talk about the largest insurer in the United States to what are some things that we can do? Well, maybe it's, giving some insurance money to a hospital just to keep it open. It's not necessarily reimbursing as an individual, but really looking at a bigger system issue like that. Other questions? I know a lot of folks pop up here as the same name on here. I know that you're probably individuals. I saw at the beginning there was folks using kind of the same link and have the same name on here. So feel free to unmute yourself or put your screen on and ask any other questions that we have in our remaining time.
Dr. Burlone, I have a question. So in relation to the statistics of, the mortality rates, one of the things that I noticed was, like you pointed out, that infections were higher in minority populations. Is there any findings related to that, like explaining why?
Not that I'm aware of. I think that we're just kind of finding some of this data now, again, because we're looking at all of the data with a more fine-tooth comb, but I haven't seen an explanation for that specifically. And I think that's where all of these campaigns are coming from, is to say, whoa, why would infection be different for specifically Latino and Hispanics? Or, whoa, why is advanced maternal age such a disparity when we look even more so at Alaska Native and American Indian? Why is that not as pronounced when we look at other racial and ethnic minorities? So we don't have an answer for that specific question about infection yet. But I'm hoping that as we are gathering this more robust data in a better way and in a standardized way, and as we're pooling data across our country and even at a district level, that we're going to be able to find some of these answers. And I've had a significant learning curve in the last 3 to 4 years of figuring out what it all means to look at maternal deaths. It seems like something so simple. You have a dead person and you figure out what they died from and you do something about it. But it's the errors in data and really combing out what goes behind that final line on a death certificate is so complex. And the ability to review these data in detail, as you can imagine, getting together committees of professionals to discuss as a group, either via Zoom or in person. A lot of the maternal mortality review committees are now meeting via Zoom because of COVID. Figuring out the nitty gritty of these things, it really is not as easy as it seems. And again, in our other issue, in a good way, is not having hundreds of deaths per year in our state, but rather having to look at trends over time and looking with other states as well to see if we can be able to detect things that aren't detectable at a small scale.
Thank you.
Mm-hmm.
As someone who fills out death certificates, I can say that it's not always clear cut to do. But I would also say that we don't really get trained in how to do it appropriately either. There's very simple block type guidelines of things that it says that you can't put in there, but it doesn't, there's no training that's really well done to teach people how to fill out death certificates in a way that data is better mineable. And I think that would be a really big help if there was something like that.
And I feel like this has come to light a lot with COVID as well, because again, the discussions around, are these numbers inflated? Are they real? I didn't want to delve into kind of how the different sides of data analysis look at maternal mortality data, because again, there's eyebrows raised when data come out, and accurately so. We should be critical of data when they come out. But the question for maternal mortality review, in the Green Journal, the OBGYN journal for the premier OBGYN journal, the first articles in last month's issue, or within the past few months, was basically criticizing the maternal mortality review data and saying, we don't have an increase. It's actually, just because of data collection. So basically we have to go back to the drawing board and say, okay, we need to gain trust with how we're collecting this data. And I think the COVID situation has really said, that death certificate's not right. These numbers aren't right. And I think more people are probably now inclined to say, gosh, this really does open a can of worms into, was it COVID-19 that killed somebody, or was it coagulopathy contributed to by this, and number 6 down the list is COVID. So, I hope that one thing that we can have learned from the controversies that go around COVID can apply to other areas of science and other areas of health in saying we don't have good training to fill out death certificates. And fortunately, we're not relying only on death certificates now, and that's the beauty of the maternal mortality review committees. So yes, I think in the past, we can absolutely say rot with error. We can say rot with less error as we look at more information with autopsies and with medical records. And that's been, I think, the biggest improvement with how we analyze the deaths, is not just having that one sheet of paper and just having one person's assessment. It now is incorporating nursing notes, it's incorporating doctor notes, it's incorporating social services, religious services, all of these things, saying there's more contributing factors than just line 1, 2, and 3 on the death certificate. But yes, I do absolutely feel, as someone who's gone through training as well, that I was not trained on how to fill out a death certificate appropriately.
Thank you so much, Dr. Burlone. Any final questions?
Well, thank you guys for joining, and keep up the good work and disseminating this information and being ambassadors for good care of women. And I hope that we get to meet again in the future.
Thank you. Everybody, you'll see links in the chat we'll be back in March with Dr. Emil, a rheumatologist, giving a presentation on diagnostic approaches to SLE and treatment updates. And then April, we'll be back with Dr. Schmidt, who's going to give a presentation on vascular birthmarks, when to worry and when to reassure. So sign up now if you would like, and thank you all.